वापस पेप्टिक अल्सर को कंटिन्यू करने वाले हैं. सो वी एंडेड दैट डे with pharmacology of all drugs used in peptic ulcer disease. So I would just name them again, the classification. We have drugs that neutralize gastric acid, drugs that reduce gastric acid secretion like H2 blockers and proton pump inhibitors, and muscarinic antagonist. We also have ulcer protective drugs जो हम not as a replacement but as a additive effect के लिए use करते हैं. And then we have anti-H. pylori drugs which are nothing but antibiotics used for eradicating H. pylori disease. So in the last session we had a very extensive discussion on starting from understanding the defense mechanisms in our GI tract, what types of cells we have in our GI tract. Then we discussed much elaborately on prostaglandins pathway and what role does NSAIDs play in acute and chronic gastritis. And H. pylori pathogenesis, its natural history of disease. We also discussed a very good and rare thing from sir की H. pylori in also कि उसे eradicate करना जरूरी है, but also as a protective mechanisms for more severe diseases. And then we saw the difference between gastric and duodenal ulcers and investigations and drugs. So I will be moving next to the H. pylori regimen. So this is the standard table taken from Harrison, which tells. So सबसे important जो हमारी ट्रिपल थेरेपी है, it is the most standard and more used. So we have the regimen is called clarithromycin triple therapy. It has PPI as standard dose according to the culture obtained and severity of the disease. PPI मतलब सिंगल या फिर डबल डोज प्रिस्क्राइब किया जाता है. क्लैरिथ्रोमाइसिन 500 mg and amoxicillin or metronidazole. Metronidazole 500 mg TID or amoxicillin. So dosing frequency is both times of the day and duration is 14 days. It is a FDA approval therapy. जो quadruple therapy है, which also includes bismuth, as bismuth we discussed in ulcer protective drugs. So it is not FDA approved, but it is used if triple therapy is not does not work properly. Then we have different therapies, concomitant, sequential. Sequential is nothing but after these are after the once the regimen of H. pylori finishes after 14 days. So patients are still recommended to take standard PPI dose along with amoxicillin and clarithromycin. And then since few years we are seeing resistance against many drugs, especially amoxicillin and others. So in resistant cases, levofloxacin therapies and other antibiotics are used. But the standard take is on clarithromycin triple therapy. Now next we move upon to complications of peptic ulcer. So what if the ulcer remains undiagnosed for a very long time? Patients presents very acutely. We discussed that day कि symptomatology और presentation हर समय ऐसा नहीं होता है कि it matches. Patient can come with acute bleeding, acute presentations and वो previously non-diagnosed भी रह सकते हैं. So complications में सबसे पहले आता है perforation. So when perforation occurs, it mostly occurs in duodenal ulcers. Pain initially upper abdomen में develop होगा and then it radiates to generalized pain till shoulder tip again क्योंकि diaphragm is getting irritated. In perforation, the contents escape into the peritoneal cavity. तो examination में हमें vowel sounds decreased मिलते हैं, and respiration we will see the patient has shallow respiration. तो हमें एग्जामिनेशन में भी काफी चीजें पेशेंट के थ्रू पता चलने लगते हैं. ऑन परकशन, liver dullness decreases because there is gas under diaphragm, and on palpation we have board like rigidity. The diagnosis is straightly made by erect x-ray जहाँ पे हमें free air beneath diaphragm मिलता है, that is the standard gas under diaphragm. और अगर चेस्ट एक्सरे अनरिलायबल लग रहा है या फिर नहीं हो पाया, तो वी हैव वाटर सोल्यूबल कॉन्ट्रास्ट स्वॉलो जो लीकेज ऑफ कंटेंट्स को कंफर्म करता है. सो परफोरेशन इज वन ऑफ द इम्पोर्टेंट कॉम्प्लिकेशंस ऑफ पेप्टिक अल्सर. नेक्स्ट वी हैव gastric outlet obstruction. It is the most common location is the region of pylorus. I hope you remember the pylorus region of the stomach. So if this is the stomach, the end point is the pylorus, and patients present with nausea, vomiting, and abdominal distension. Large contents of gastric content are often vomited, and food eaten 24 hours or more previously may be recognized. तो अगर आपके पास पेशेंट वॉमिटिंग के बहुत एपिसोड्स लेके आ रहा है एंड वो बोल रहा है कि भी वो भी मेरे वॉमिट से बाहर निकल रहा है, तो दिस नीड्स टू बी इवेल्युएटेड एज अ कंसर्न. वेस्टिंग एंड डिहाइड्रेशन और फिजिकल एग्जामिनेशन हमें बहुत विजिबली दिखेगा बिकॉज ऑफ द diagnostic of gastric outlet obstruction. Endoscopy should be done after the stomach has been emptied using wide bore nasogastric tube, and intravenous correction of dehydration is undertaken in severe cases at least 4 liters of isotonic saline and 80 millimole of potassium may be necessary. So we need to consider both the levels of hydration and potassium in the patient who comes with gastric outlet obstruction. As a UG student, we need to remember the differential diagnosis of gastric outlet obstructions. So there are 4 DDs. First, there might be a fibrotic stricture from duodenal ulcer. So it is managed by balloon dilatation or surgery. The next differential diagnosis might be edema from pyloric channel or duodenal ulcer. So it is managed by PPI therapy. Carcinoma of antrum, so it definitely requires surgery, and adult hypertrophic pyloric stenosis. So these 4 DDs are standard and need to be remembered for gastric outlet obstruction. In management, in some patients, it is said PPIs, according to evidences, PPIs heal ulcers and relieve pyloric edema and overcome need of the surgery. Partial gastrectomy is necessary. It is done after 7-day period of nasogastric aspirations. So these 2 complications, perforation and gastric outlet obstructions, need to be remembered. Now here we officially conclude with peptic ulcer disease. This is one added topic which is important because many patients of peptic ulcer disease or patients who develop ulcers in GI tract, they might need gastric resections or vagotomy surgeries. So we need to remember, in medicine, we need to remember the complications after that surgery. So up to 50% patients who undergo there will be they might be very mild, but they will be there. So one of the important one is dumping syndrome, which actually is कि rapid gastric emptying होता है and there is distension of proximal small intestine. So this is called early dumping, जिसमें गैस जो भी हम खाएंगे it is rapidly emptied, distension of intestine होगा, hypertonic contents draw fluid into the lumen, and the patient experiences diarrhea and abdominal discomfort. For and early dumping will start with just मतलब खाना खाया and the patient experiences in next 20 to 30 minutes. So for avoiding this complication, early dumping, doctors usually prescribe patients that they should avoid high carbohydrate rich meals. Late dumping starts at 1 to 3 hours. It is characterized by reactive hypoglycemia, nausea, tremor, and sweating. So it is relieved by eating more. Uh, matlab, it might seem as something of type like duodenal ulcer, but this is very different. And अगर diet और lifestyle में the patient makes good changes कि carbohydrate rich diet बहुत कम हो गया है, carbohydrates नहीं है diet में ज्यादा, तो डंपिंग सिंड्रोम के इफेक्ट्स रिलीफ होने लगते हैं. And diarrhea and malabsorption diseases might increase after vagotomy surgeries. So, uh, 1 to 2 hours after eating, the patient might observe symptoms of malabsorption and diarrhea. The patient might also experience weight loss and anemia क्योंकि हमने सर्जरी परफॉर्म की है एंड वी सॉ कि आयरन डेफिशिएंसी इज मोस्ट कॉमन जब हम पेप्टिक अल्सर डिजीज को ठीक कर रहे हैं ड्यू टू डिक्रीज्ड एब्जॉर्प्शन एंड एवरीथिंग. तो दीज टू माइट बी कॉमन एंड देयर माइट बी मेटाबॉलिक बोन डिजीजेस. गैस्ट्रिक कैंसर के लिए कोई ऐसा श्योर शॉर्ट एविडेंसेस नहीं है कि द रिस्क इंक्रीजेस और डिक्रीजेस, बट Davidson says ki the patients might also have decreased risk or increased risk. So the next thing we have to study is matlab we have to see is about new onset dyspepsia, which is important because if more than a 40-year-old person presents us with alarming symptoms and we exclude by history कि GERD नहीं है, biliary pain नहीं है, inflammatory bowel disease नहीं है, एरोफेजिया नहीं है, and any medication related dyspepsia नहीं है, तो we move on with non-invasive H. pylori testing. Then अगर वो पॉजिटिव आता है तो एंटी एच पाइलोरी थेरेपी फॉर 4 weeks, and 4 weeks after therapy we confirm eradication by UBT, and if the symptoms remain or reoccur तो we refer them to gastroenterologist. अगर जो डिस्पेप्सिया है उसमें एच पाइलोरी नेगेटिव आता है तो we start a empirical trial by starting a H2 blocker or refer to the gastroenterologist. So new onset dyspepsia is an important indication कि क्योंकि after 40 years at a mid age it is starting, तो it is also a strong indication कि अगर patient बहुत strong history दे रहा है dyspepsia का तो we need to move on to even endoscopy at the earliest. There are some important points from the point of view of clinical pharmacology, that magnesium containing antacids should be avoided in renal failure. Antacids should be avoided in congestive cardiac failure, except occasionally because they contain sodium salts. So they might harm the functioning of heart more in patients of cardiac failure. PPIs, as said, should be given 30 to 1 hour before food, 30 minutes to 1 hour before food. Sucralfate may be used only in proven peptic ulcer, and this is the medicine itself is quite expensive, so it is not generally preferred. Most anti-ulcer drugs, particularly ranitidine, are available as over-the-counter medications and often irrationally used. So history of such drug use should be elicited. Now we move on to the last discussion in related to peptic ulcer and gastritis discussions, which is we might these questions come as very as MCQs or as DDs, while we see a patient of when we approach a patient of peptic ulcer disease. So one of them is autoimmune chronic gastritis, which results from autoimmune damage to the parietal cells of the gastric glands. It involves body of the stomach and spares the antrum, which we saw कि peptic ulcer में ऐसा नहीं होता है. And in some patients, gastric atrophy leads to loss of intrinsic factor. So the patient develops pernicious anemia with time. Then we have Menetrius disease, very rare condition, very rare. Gastric pits are elongated and tortuous, which with replacement of parietal cells and chief cells by mucus secreting cells. So gastric glands में जो हमने last session में पढ़ा था deeply very about the gastric glands, उसमें parietal cells and chief cells get replaced by mucus secreting cells. And then we have Zollinger-Ellison syndrome. It is also a rare disorder. It is gastric acid hypersecretion and severe peptic ulcerations. So unlike peptic ulcer disease, जहाँ पे the ulcer might be present in one location, Zollinger-Ellison syndrome में patient have multiple ulcers at different points. So acid output may be so great that it reaches the upper small intestine and decreases the luminal pH less than 2, which is concerning. Clinical presentation patient का is severe and multiple peptic ulcers in very unusual sites, and there is very poor response to standard ulcer therapy. So while we see the patient the patient might have peptic ulcer disease, हम उसकी regimen start करते हैं, and we see that there is very poor response to the patient is not responding to any standard ulcer therapy. So we might so Zollinger-Ellison syndrome might be a exclusive, matlab after exclusion it is a diagnosis of exclusion. And then the management is, so Davidson says ki there should be continuous therapy with PPIs and high dose can be successful in healing ulcers. It is still not proven because again it is a rare disorder, so studies have been less. And somatostatin analog therapy may reduce gastric secretion. If you remember, we saw how somatostatin secreted by D cells decrease the gastric secretions by inhibiting the action of G cells. So their analog therapy may reduce the gastric secretion. At the end, what we have discussed since the last peptic ulcer session and today, I wanted to highlight some important points from the discussion. So the most common causes of duodenal gastric ulcers are H. pylori infection and use of NSAIDs. H. pylori is associated with duodenal and gastric ulcers, chronic active gastritis, gastric adenocarcinoma, and gastric mold lymphoma. If you remember, gastric mold lymphoma is a sequelae of pangastritis, जो H. pylori के natural history of course of disease में आता है. Treatment of peptic ulcers require acid suppression with proton pump inhibitors to heal the ulcer, as well as antibiotic therapy of H. pylori infection if present to prevent reoccurrence. This point, which we studied just now, patients with dyspepsia who have red flag symptoms, new dyspepsia after age of 45, weight loss, dysphagia, evidence of bleeding or anemia should be referred for an early endoscopic examination. This is a very important point. We need to rule out these red flag symptoms before we move to any empirical therapy. अगर patient कोई भी इनमें से complaint लाता है, we need to get it referred for an early endoscopic examination. Other patients with dyspepsia who do not have red flag symptoms may be tested for H. pylori and treated first. Antibody tests show evidence of infection but remain positive for life even after successful treatment. So urea breath tests are evidence of current infection. Common treatment regimens for H. pylori infection include 14-day course of proton pump inhibitor in high doses along with antibiotic therapy, which may include clarithromycin and amoxicillin, metronidazole, and tetracycline. cycline along with bismuth compound. So if bismuth is involved, it is called a quadruple therapy. If bismuth is not used or any sulfate is not used, then it is standard clarithromycin triple therapy. So we end with peptic ulcer disease. Now today the additional topic we are going to study is a very small but very important as a clinical
Akriti,
type.
could we take some questions and discuss
Yes,
about
yes, yes.
before
Yes, sir.
standing GI?
Yes, sir.
So hello, Akriti. Am I audible?
Yes, sir, you are audible.
Yeah. So I'll just add a couple of things to the presentation of peptic ulcer disease. So one thing is you mentioned regarding vagotomy. So often one thing that you have to always keep in mind is that whenever somebody is mentioning vagotomy, you have to be very specific about what type of vagotomy is being performed. Whether it's a truncal vagotomy, whether it is a highly selective vagotomy, or what the type of vagotomy is. Because uh, along with vagotomy, often surgeons will do an additional pyloroplasty also. So, like pyloroplasty means they'll incise the pylorus. Of the you can have to consider the pyloroduodenum or the pyloroduodenal complex as a single unit. It functions like a valve mechanism, and it has to relax and open up so that the food contents has to go into the duodenum. So often whenever we are doing a vagotomy, the terminal branches of the vagus are also cut. So what happens is the pyloroduodenal complex will get spasms or will go into a state of contraction and will prevent the food contents from going uh, into the duodenum. So it will present like a gastric outlet obstruction, even though there is no outlet obstruction per se. So often your vagotomy is also associated combined with a pyloroplasty. So without pyloroplasty, your patient will have symptoms of outlet obstruction, recurrent vomiting, bloating, early satiety, all this stuff. If there is pyloroplasty, also there can be an increased risk of developing dumping syndrome. Because again, this valvular mechanism, once the pyloroduodenal complex is free, then the valve mechanism is gone, there can be an increased risk of developing dumping syndrome. So that is also another contributing factor to the your complications like dumping syndrome. So that is regarding your this vagotomy and valvuloplasty. Now, and another thing is your red flag symptom. See, one thing that you have to make sure is with the advent of PPIs, like rampant use of PPIs, like for almost every other condition, people start prescribing PPIs or people take PPI without prescription over the counter. So with that, some of these red flag symptoms, like presence of previous bleeds and all those stuff, they have lost its importance. But there are certain hard signs. That is some things which you cannot ignore. That is one of it is weight loss. You can never ignore weight loss. Dysphagia. Again, cannot ignore dysphagia. If you remember from our first class, I told you dysphagia is almost always pathological. So dysphagia, weight loss, these things can never be ignored. And another thing which you can't ignore is, we have to go into like and evaluate is iron deficiency anemia. Unexplained iron deficiencies anemias also you cannot ignore. So these are those few findings that which like with the advent of PPI, some of your red flag signs have lost their importance, but still these hard signs has to be considered very important. Okay. And I recently had a very interesting case. Maybe at the end of the session, I'll just share that story with you. So let's finish it off first, and then I'll come back to the case.
Sir, could I ask a question on the peptic ulcer
Yeah,
management?
sure.
Sir, in the part that we discussed, we actually saw what were the how do we diagnose H. pylori infection. So, in a case of dyspepsia, just for revision sake, if I say that if we do an endoscopy and then we immediately do a rapid urease test on the biopsy sample, and also we send the
Mhm.
sample for histopathology. Sir, is this the
Mhm.
correct approach for diagnosis, sir?
So that is a commonly used approach. wherever endoscopy is available, we do a simultaneous rapid urase test as well as a biopsy for direct histopathological evidence of H. pylori. But wherever the endoscopy is not, like, there are another school of thought where we say like non-invasive tests first, then later on endoscopy. So in those conditions, like whenever the like urea breath test is available, we go for urea breath test first and see if there is a response. Try treating it, and then come back to endoscopy. So that is also an accepted algorithm where we can go for a non-invasive testing first, then later on endoscopy.
Okay, sir. So that was about the diagnosis. Like after we have diagnosed the patient to have H. pylori infection and peptic ulcer disease secondary to H. pylori infection, we are going to start the triple therapy. So the most common
Mhm.
therapy even in our hospital is clarithromycin, amox, and metronidazole with PPI, sir. Sir, but after giving 14 days, how should we continue the treatment with PPI, and how should we assess whether the treatment with the triple drug regimen has failed or not, and when should we start the quadruple regimen?
So one thing is in India, like there has been multiple studies on like the antibody resistance profile of H. pylori in India. So in Indian population, your metronidazole resistance has to be found to be much higher. So here, uh, like our Indian Society of Gastroenterology, our ASG guidelines all don't support much use of metronidazole in part of the regime. We give amoxicillin and clarithromycin along with PPI as well as bismuth and an additional thing that has come up is that there are certain bacteria which can actually reduce the risk of uh, like recolonization as well as increase the H. pylori eradication. So that can also be tried along with it.
Sir, then after 14 days again we have to check symptoms, or sir, or do we have to
No,
do the
usually we give a sequential therapy where after the initial 2 weeks of like your triple therapy, we go ahead and continue the PPI for at least up to maximum of total of up to 6 weeks, 4 to 6 weeks we can continue it. Usually that is what is accepted in Indian standards nowadays. That is what the ISC guidelines also say.
Okay, sir, thank you. Akriti, you can continue with GERD.
Yes, thank you. Thank you, sir. I think most of the questions that I plan to ask are already discussed. So we will move to GERD. It is the full form of GERD is gastro-esophageal reflux disease. So by its standard definition, it is a condition in which there is retrograde flow of gastric contents into the esophagus or beyond into oral cavity, larynx, or lungs, resulting into esophagitis and inflammation of mucosal surfaces, resulting in heartburn effects. It 15% of the general population might present with GERD symptoms. Reflux is normally followed by esophageal peristaltic waves that efficiently clears the gullet. Alkaline saliva neutralizes the residual acid and symptoms reduces after the reflux. Understanding the pathophysiology is important. So we have different factors which aggravate and are a part of pathophysiology of GERD. So first we move to obesity or dietary factors. So of course, जिनके diet में fats, chocolates, any food containing caffeine, tea, coffee, alcohol, and other substances like this, अगर इनका एक prolonged duration में intake होता है, patients are susceptible to GERD. Then if we have one of the main causes is abnormal LES, that is the tone of the lower esophageal sphincter is reduced. So normally in a physiological state, it is tonically contracted under normal circumstances, relaxing only during swallowing. It is physiological. But in abnormal LES sphincter, in abnormal LES, we have reduced tone and inappropriate relaxation. So acid exposure increases. Then we might have defective esophageal clearance. So it is commonly seen in esophagitis since persist after esophagitis has been healed, even by acid suppressing therapy. And one of the factors is delayed gastric emptying matlab, because of the more secretion of the acid and the food is not getting cleared. There is defective esophageal clearance also, and uh, tone is also reduced. So gastric emptying is delayed. And in conditions of pregnancy and obesity, we have increased intra-abdominal pressure. So the pregnancy and obesity are very established predisposing causes of GERD. And hiatus hernia. So hiatus hernia causes reflux because the pressure gradient is lost between abdominal and thoracic cavity. And we have uh, two types of hiatus hernia. First is rolling or paraesophageal. We can see the barium meal showing a large paraesophageal hernia with intrathoracic stomach. And the next is sliding hiatus hernia, in which the barium meal is showing the gastric volvulus, complicating a sliding hiatus hernia. Hariom sir, I would like to ask you after the end of GERD to explain us about more about hiatus hernia because the content was very less in the book. So more practical point of view and about barium swallow and patient factors. Of course, the visceral sensitivity and patient's vigilance. The whatever the doctor prescribes in the diet and lifestyle factors, how kitna patient follow karta hai does play a role. So how does a patient present? Most common, of course, is heartburn. The upper मतलब esophagus वाले region में and chest में we feel heartburn and regurgitation often provoked by bending, straining or lying down. So many patients complain कि ये सारे जो symptoms होते हैं हम खाना खाते हैं और तुरंत सो जाते हैं, which is also a very common lifestyle problem in Indian populations कि खाने के बाद they don't give body enough space and often go to sleep soon. We discussed water brush in the first GI session. There is reflex salivation due to stimulation of salivary gland when acid enters. So the patient feels quite sore something in the mouth when there is a reflux. And some patients also complain of they are woken up at night by choking as reflux fluid irritates the larynx. So they might puff and the patient complains कि बहुत लंबे टाइम से मुझे puff हो रहा है. There is atypical chest pain because of esophageal spasm, and of course, and many times the voice turns hoarseness, which is called acid laryngitis, and it is due to the chronic reflux. GERD in old age needs a good consideration because the prevalence is higher and the severity of symptoms does not correlate with degree of mucosal inflammation. So the patient might have gone into complications, but symptoms उन्हें बहुत normally लगेगा. Complications such as peptic strictures or bleeding from esophagitis are common, and recurrent pneumonia. Consider aspiration from occult GERD. So complications include two important. There are quite few complications, but esophagitis and biliary esophagitis are two important complications of GERD disease. Esophagitis may endoscopic findings may we might see mild redness to severe bleeding ulceration with stricture formation. And in Barrett esophagus, we have it. Barrett esophagus, as we know, is a pre-malignant condition in which the squamous lining of lower esophagus is replaced by the columnar cells. And it is an adaptive responsive feature of the body. So it might lead to then esophageal cancer. And Barrett esophagus का management, it is still in development. Endoscopic therapies can induce regression and at present may be used. High grade dysplasia or intramucosal cancers uh, may help in may be solved by different endoscopic therapies. And the third complication is, of course, anemia, iron deficiency anemia, unexplained iron deficiency anemia as a consequence of occult blood loss from long-standing esophagitis needs to be considered. And patients with large hiatus hernia may have bleeding from subtle erosions in the neck of the sac. So these lesions are called Cameron lesions. Then we have benign strictures and gastric volvulus as different complications. For investigation, young patients without worrying clinical features like dysphagia, weight loss, or anemia can be treated empirically without investigations. And over 50 years of age, if what we saw earlier in peptic ulcer disease, the patient has new onset presentations with atypical features. So endoscopy is the treatment of, sorry, I have written treatment of choice, investigation of choice for the same. There is also a 24-hour pH monitoring. It is indicated if the diagnosis remains unclear. Surgical intervention, if it remains unclear or surgical intervention is suspected. So this is a photo how the patient has been tethered a slim catheter with a terminal radiotelemetry pH sensitive probe. So the patient goes on with their normal life, normal activities हो रहा होता है, and the pH gets recorded. So if more than 6 to 7% of time pH is less than 4, so it is diagnostic of reflux disease. Treatment, we just need to remember the algorithm कि symptoms अगर GERD के present होते हैं, so antacids के साथ we can start. And proton pump inhibitor, we can ask the patient at full dose. If there is good response, then we move to proton pump inhibitor at maintenance dose, and then move on to H2 receptor antagonist. If there is poor response or there are more side effects, then we need to reconsider the diagnosis or consider pH monitoring. If pH monitoring is positive, then we need to move to fundoplication. So we complete GERD here. Sir, I would, the related to PPIs, most of the doubts are just cleared. And I just needed to ask more about this pH monitoring and what is fundoplication is, because the book didn't mention it it has mentioned it very briefly.
Yeah.
And as a MBBS student, what is an acceptable strategy when a patient comes to us with many different symptoms? बहुत बार पेशेंट बस बोलते हैं कि हमें एसिडिटी है लंबे टाइम से, हमें गैस्ट्राइटिस है, आजकल गूगल वाले पेशेंट्स दे प्रेजेंट विद दीज. So how do we distinguish functional dyspepsia, GERD, and peptic ulcer clinically? How do we approach this? And again, the one I asked, hiatus hernia.
And regarding hiatus hernia, so
Yes.
I'll just introduce few concepts to you, and then we'll come back to your question. So regarding GERD, one very important concept that you need to know about is regarding your anti-reflux barriers. So there are certain biochemical, neural, as well as mechanical barriers which prevent reflux. So it is like a three tier of esophageal defense. This Your acid, whenever it comes into the esophagus, it will cause damage to the esophagus. Because your esophageal mucosa is not prepared or not good enough to handle such low pH. So it's a complex mechanism of three different aspects. One is a mechanical barrier where you have a complex lower esophageal sphincter, where it is composed of both your lower esophageal sphincter, your diaphragmatic crura, and then it is also contributed by the position of the lower esophageal sphincter. So your LES is actually intra-abdominal rather than above the diaphragm. It's intra-abdominal, under the diaphragm. So because of that particular location itself, the pressure on the LES from the abdomen. There is intra-abdominal pressure is also contributing to the mechanism of anti-reflux or lower esophageal sphincter pressures. And along with that, there are certain mechanical aspects like your phrenoesophageal ligaments. There is a ligaments which connect your esophagus to the diaphragm. So these ligaments are also acting as a barrier. So that is the mechanical ones. And then because of the position of the esophagus with respect to the axis of the stomach, this is called as the angle of this. So because this angle of this is actually a very acute angle. That is the angle between the esophageal lumen and the angle between the stomach axis. So because of this acuteness, what happens is there is no mechanism that will uh, directly cause the reflux of contents into the stomach. So this anti-reflux barrier mechanism is what is getting damaged whenever there is a hiatus happening. So either it can be because of the laxity of the ligaments, the phrenoesophageal ligaments get lax, and because of that, this acute angle of this will become an obtuse angle or the acuteness decreases. And the other mechanism is where a part of the stomach itself will permeate into the supradiaphragmatic compartment. So depending upon that, it can be a sliding or a rolling hiatus hernia. And it can also be a complex hiatus hernia depending if there is an additional lumen, because sometimes even the colon also can herniate along with uh, the fundus of the stomach as well as the parts of the stomach. So that can be a complex hiatus hernia. So that is regarding your anti-reflux barriers. So one interesting question there is, like, we know that your the reflux is because of the acidic contents coming into the esophagus after your from your stomach. So my question is, usually most of the patients will complain of reflux symptoms after having a meal, right? So usually what happens to the acidity in the stomach when the meal goes there, the food acts like a buffer and will reduce the acidity. So why is the patient getting reflux symptoms after having food, even though food acts as a buffer?
Sir,
Any any
is it
ideas regarding?
because of hypersecretion or reduced defenses of the stomach, sir, or because of excessive acid secretion?
So that is one. So one thing is there could be an excess acidity in the stomach, which the esophagus is not prepared for taking. Right? But the most important one, or the concept there is that there is something called as an acid pocket. So an acid pocket is a concept where, like, even though your your gastric cardia, the food in the gastric cardia will remain unbuffered. That is the pH in the gastric cardia, that is the uppermost part of your stomach, that might remain unbuffered even if there is food. So that is the concept of acid pocket, where there can be a small pocket of hyperacidity even without uh, any hypersecretion of acid. Okay, that is because this particular zone in the cardia that is close to the esophagus, that might remain unbuffered even with the presence of food. So in these regions, whenever there is a hiatus hernia, what happens is acid pocket will be much bigger because this part of the stomach is already excluded from the rest of your food buffering areas. So the acid pocket becomes much bigger, and because of that, patients with the hiatus hernia might have more significant gastroesophageal reflux symptoms. So that is the concept of acid pocket. And another another important thing is that is gastroesophageal reflux a normal phenomenon?
Sir, in normal circumstances, some amount of acid can go into the esophagus, sir, because it is not 100% sphincter, sir, actually, the lower esophageal
Yeah,
part. When the
yeah,
patient has persistent symptom, definitely, sir, it should be gone.
yeah. So gastroesophageal reflux into the esophagus is a normal phenomenon. There is a mechanism called as esophageal acid clearance, which actually helps the esophagus to clear the acid in the normal circumstances also. So sometimes this can get deranged. So the esophageal acid clearance, it has got two aspects. One is the volume clearance, where the whatever reflux volume is there in the esophagus is pushed back into the stomach by the esophageal constriction, so peristalsis. So that is the volume clearance. And then there is excessive salivary and esophageal glandular secretions. So because of these glandular secretions, this is like washing off the gastric acid. So that can also contribute to the esophageal acid level. So one thing that can accentuate or increase the gastroesophageal reflux is when the patient is having a delayed peristalsis, or because of either it can be because of severe esophagitis, or it can be because of age-related esophageal dysmotility, or it can be because of conditions like hypothyroidism, uncontrolled diabetes. In all these aspects, where the patient will have peristaltic dysfunction. So because of that, there is a weak peristaltic construction contractions, and that will reduce the volume clearance. So the amount of acid that is refluxing into the stomach into the esophagus normally also will have reduced clearance. So that will result in symptoms. Another is uh, the in some patients the salivary and esophageal glandular production is also reduced. In that also, these patients might have got delayed or reduced esophageal acid clearance. Now, one important aspect is that sometimes your patient might tell you that they have just increased salivation. So that could also be a defense mechanism of the body where, because of reflux, the patient has got actually increased salivation. So that is one symptom of GERD, which sometimes you might miss. The patient might tell about hoarseness of voice. The patient might tell about like heartburns. Here, this could be one symptom that might be missed. And patient might tell you that they have got increased hypersalivation. And again, like in patients who are smokers and those people who have got certain conditions like Sjogren syndrome, or age-related salivary gland atrophy, or who have had a radiation exposures. So all these patients, the salivary glandular saliva production will be much less. So that can also present with GERD-like symptoms because of delayed esophageal acid clearance. So these are like two concepts which I would like to introduce to you guys, because these are not mentioned in the textbook regarding like both itis hernia as well as this acid pocket and this concept of esophageal acid clearance. So is there anything else you would like to ask me regarding this particular topic?
Sir, this specifically like continuous acid exposure in the lower part of the esophagus. So, esophageal epithelium is not prepared for this acid. So, it converts into a different epithelial. So, that is the metaplasia. So, in case of
Yeah, yeah.
metaplasia, how we are obviously going to give PPIs for a long term. So, is this
Mhm.
epithelium going to regenerate, or we have to
Yeah,
follow it
yeah.
up regularly?
See, one thing is like, uh, see, whenever there is intestinal metaplasia there, you are thinking about a Barrett-like condition or a Barrett esophagus. So, for as long as there is no dysplasia associated with it, that is, the epithelium might change, but the cells will still remain normal cells. So, as long as the cells are normal, they can revert back to the previous squamous epithelium if we are treating with PPIs. So, that is one thing. But once dysplasia sets in, so it can be low grade or high grade, but once dysplasia sets in, even with display, like there are some newer drugs like PCAPs which have actually found benefit even with the presence of dysplasia. So, like there are some new papers that are coming up which tells about PCAPs. There is some drugs called vonoprazan and pexuprasan. So these are upcoming studies which say that even with some amount of dysplasia, it is reversible by uh, therapy. But once the dysplasia is there, we have to serially monitor. That is what the current evidence states. Even though there is evidence that there is reversibility with drugs, once dysplasia is there, we have to follow it and evaluate it with endoscopies.
Thank you, sir.
Thank you, sir. I all the doubts have been cleared. Thank you for the clearance, and I think Shri, if there are no more doubts,
Sir is going to share some case that he was saying.
sir, you
Yeah.
say
I
about the
almost forgot.
story.
Yeah, I almost. So So like this case, like we made the diagnosis like a couple of days back. We had this patient probably 2 to 3 weeks prior. So I got a consultation from our neurologist. So the patient presented with ataxia. So the patient is a 45-year-old male patient who presented with ataxias and nystagmus. So he was admitted in the neuro side with features of cerebellar degeneration. They were suspecting some sort of cerebellar degeneration, and they were also thinking about like some long track signs were also there. He had delayed reflexes. He had significant ataxia, and on examination also he had gaze about in nystagmus. So as a part of the evaluation, they did a whole screen. So whenever you're seeing a case of ataxia with the long track signs and cerebellar degeneration, we'll always think about two things. One is a stroke, vascular phenomenon. Other is a nutritional thing. What is a nutritional thing that you think about? And just to refresh my own neurology with
B12
you guys.
deficiency.
Yeah, B12 deficiency, definitely. So we have to think about long track. We have to think about subacute combined degeneration here. Because there is ataxia, there is some amount of weakness, long track signs, and some cerebellar gaze woggness diagnosis also. So this patient was found to have B12 deficiency. So they were treating the B12 deficiency, but one thing was alarming that the patient persisted, like continued to have uh, muscle weakness. That is, patient had excessive fatigability, muscle weakness, and all that. So they we went sent the electrolytes and he was found to have hypokalemia. So they thought, okay, fine, the possibility of hypokalemia is there, but there is no precipitating factor for hypokalemia. So they evaluated for hypokalemia, refractory hypokalemia, which is not getting corrected with IV potassium. One important thing that we'll think about whenever a patient is having hypokalemia, refractory hypokalemia is what else would
Hypomagnesemia.
we look for? Hypomagnesemia. Very
Yeah.
good. You guys are very evident in the approach to hypokalemia. It's very good. So we checked for magnesium, and magnesium levels were probably very low. So it was hypomagnesemia. So we corrected the magnesium levels, and the hypokalemia got corrected. His myopathy was improving, his weakness was improving, but still we did not get any cause for hypomagnesemia. So that is the point where they asked the gastroenterologist, our team, to involve. So we see whenever we are finding vitamin B12 deficiency, there is either a nutrition defect or it could be an atrophic defect because of an autoimmune gastritis. So this is our thought. But why would such a patient have significant hypomagnesemia? So at this point, we went back into the history and we found out one thing that is very like we see it in almost all our patients, but we often ignore it. That is regarding the drug history. So we mentioned hypomagnesemia is a cause of or a side effect of what? Long-term PPI use. So this patient has been on PPI for maybe 4 or 5 years. He has been continuously taking antiprazole over the counter for quite long. Initially, he was prescribed it by some GP who had started him when he was put on some NSAIDs. And then later on, he continued taking PPA because he was without the PPA, he was having some issues. So what we did was we we thought, okay, fine. Now this is because of classical PPI overuse. This patient is developing hypomagnesemia. And because of hypomagnesemia, he is developing hypokalemia. And because of the low acid, because of very low acid, what happens is there can be associated like atrophic gastritis also, and that is contributing to this vitamin B12 deficiency. So this is our thought process. So what would our like normal plan of action be? So what would you usually do? A patient is on long-term PPA overuse or abuse. We tell the patient that, see, you have been abusing PPA for long term. You have to stop PPA. So we stop the patient's PPA. Now, do you know what happened after that? 1 week after stopping the PPA, patient got readmitted with severe diarrhea, and abdominal pain. So at this point, like we were wondering what is actually causing diarrhea and abdominal pain for this patient. And we asked the patient what did, like, yeah, our usual history goes to the food habits and all stuff. And he was telling that every time he stops PPI, he gets diarrhea. And that is why this guy has been taking PPI for all these years. Just, just because he was that afraid of his diarrhea and abdominal pain episodes that he is like, terrified of stopping PPA. But then this time, gastroenterologist only asked him to stop the PPA. So he confidently stopped PPA. And then this time, what we went into, he was having watery diarrhea, severe diarrhea, dehydration, and along with that, dyslipidemia, all the stuff. So this time, we went back in and we did an endoscopy for him. That is, at this point only, we are doing an endoscopy for him. At this point, what we found out was that previously, like he did not have any abdominal pain or per se GI symptoms, but this time he was having severe ulcerations in his entire duodenum and antrum. Now, does anything lit up here? A patient who is on
So this could be Zollinger Ellison, sir.
this,
या
absolutely.
फिर
This patient was
hypergastric.
Yeah, this patient is actually having Zollinger-Ellison syndrome, because hypergastremia and hypervipioma. So because of that, when the patient is on PPA, naturally the gastrin levels will be much lower. So that was actually protecting him. But the PPA was causing all the side effects of hypomagnesemia and all that stuff. But once the PPA got stopped, he was developing hypergastremia, and because of that, he was developing these ulcers. So it was classical Zollinger-Ellison syndrome. Then we went ahead with the DOTA PET, and we found out that he was having multiple duodenal nodules, small nodules of NET were there, neuroendocrine tumors were there. And subsequently, we took him up for, I think right now he's being posted for surgery right now. And he's being put back on the PPS again. So this is one interesting case.
Sir,
Zollinger-Ellison
even
syndrome
for
is
this
came
patient, sir,
across.
sorry, sir, this patient might
Yes,
have
sir.
to be evaluated for MEN1 and MEN2 also, sir,
Yeah,
because
yeah,
ZE
yeah.
syndrome
Definitely,
will
definitely.
be in combination
Once,
with other.
yeah, yeah. Once we get a like neuroendocrine tumor, the whole battery of tests for MEN1 and 2 and all that stuff will come into it. So he's being evaluated. I don't think he has got any like MEN syndrome. It's purely a neuroendocrine tumor, isolated NET developing neuroendocrine syndrome, hypergastruloma. So this is how sometimes hypergastrinoma Zollinger-Ellison syndrome can present. It can end up in the neurology department, and then we'll have to chase the whole thing back to this particular thing. It was very interesting. Like, so we were discussing this case last day, and I was telling my PG. So recently we are discussing regarding Zollinger-Ellison syndrome in another class, and now a case comes up, which is Zollinger-Ellison syndrome. So that kind of things can also happen.
Sir, this different investigation that we study usually in context of esophageal disorders like pH monitoring
Yeah,
and other
yeah.
investigations. Even, sir, previously there was a lot of focus on barium studies. So, sir,
Mhm.
what are the specific indications for pH monitoring and like barium studies, etc.? Or is it barium studies is completely replaced with
So
endoscopy, sir?
right now we don't do any more variant studies. See, unless it is variant studies obsolete only because there is esophageal pH metry as well as esophageal manometry. And there is something else that is coming. It's called as endoflip. It's a endoscopic functional luminal assay. That is, it will assess the functions, both pH as well as the manometry. It can be combined together to call something called as flip. So That that is also coming up. So because of that, barium studies as per se, it is obsolete. But again, there are certain conditions where we actually do a timed barium swallow. Usually, timed barium swallow is performed whenever we are suspecting an atelectasia rather than any mechanical uh, dysphagia or mechanical esophageal disorder per se. So usually, we don't do a barium esophageal exam, but manometry and pH meter we do almost like on routine basis for all almost all cases of dysphagia with significant reflux disorders. We do a manometry and pH meter that we do.
Thank you, sir. So we have completed the peptic ulcer disease and also have briefly discussed about esophageal disorders, though only GERD was covered in some detail. Uh, Now we have to read back the books and again we have to come back with any doubts we have. And next topic we will be deciding soon online what we can take. So thank you so much, sir, for your detailed explanation and sharing the case scenarios as well. I think it will help us remember the details of this case. And we will upload this video on YouTube and also the previous one. And then we will share the links of this. Thank you so much, sir.
Okay.